Hello, I'm Ros Glasspool and I'm a consultant medical oncologist based in Glasgow in Scotland, and I'm also chair of the IGCAN. I'm delighted to welcome you today to this IGCAN webinar on preventing the most common female cancer women have never heard of. This is part of our programme for the Uterine Cancer Awareness Month in June. Endometrial cancer is the most common type of uterine cancer and its incidence is rising across the world, but many women remain unaware of the symptoms and the risk factors associated with endometrial cancer. So I'm so pleased to be able today to introduce Dr. Sarah Kitson, who's a clinical lecturer at the University of Manchester and a gynae oncologist at St Mary's Hospital here in the UK. She's an expert in endometrial cancer prevention, amongst many things. And on that note, I'm going to hand over to you, Sarah, for your presentation. Really looking forward to hearing it.
And thank you very much for asking me to speak today. And I'm going to talk to you about preventing the most common female cancer women have never heard of, or how to reduce womb cancer diagnoses. Just to say I've got no conflicts of interest to disclose. So womb cancer is a global problem. As I'm sure we're all aware, in 2020, there were 417,000 diagnoses made. And as you can see in this graph, this map, sorry, on the left-hand side, most of these cases are diagnosed within North America and Europe, as shown in the darkest shades of blue. And countries in these regions also have some of the highest levels of female obesity, as you can see in the map on the right, with corresponding areas in darkest shade of red. And this link between high body weight and womb cancer is now very much firmly established. But what I think it's important to note is that womb cancer is not just a disease of high-income nations, and almost all regions around the globe have seen an increase in the number of womb cancer diagnoses over the last 30 years. The greatest percentage increases occurred in high-income Asia Pacific, North Africa, the Middle East, and Southern Sub-Saharan Africa. And this is thought to be due to changes that have occurred in lifestyles in these regions, with corresponding increases in levels of obesity and overweight. And this has been driven potentially by increasing access to high-calorie containing foods and reducing levels of physical activity. But there are a number of other contributing factors beside the rising obesity rates. Globally, women are living longer, family sizes are decreasing, diabetes is on the rise, and fewer women are having a hysterectomy for the treatment of heavy periods and fibroids. And all of these factors together contribute to this increase in womb cancer diagnoses. And this isn't a problem that's going to go away. Estimates suggest that by 2050, we'll be potentially seeing almost 700,000 diagnoses of womb cancer each year worldwide. And whilst the majority of womb cancer diagnoses are made in women that have already gone through the menopause, there has been a sharp increase in the number that occur in younger women. And data from the States suggests that now 1 in 8 endometrial cancer low-grade diagnoses occur in women under the age of 50, and 4% occur in those women in their 20s and 30s. The increasing prevalence of obesity in younger women is the most likely explanation, and this only adds to the challenges facing both patients and their doctors when trying to manage these cases. Of significant concern is the widening inequity and inequality that we see in disease burden across different ethnic groups, even within the same country. In the States, womb cancer incidence is rising twice as quickly in women from non-white backgrounds than it is from white women. And these women are also, unfortunately, more likely to have aggressive histological subtypes of the disease and to present with advanced disease. And these factors, together with worryingly different levels of access to medical treatment, has resulted in an increased risk of dying from womb cancer among Black and Asian women. Although survival after a diagnosis of womb cancer is improving across the world, probably because of increased access to treatments and better treatments, women diagnosed with womb cancer in low-income countries continue to have a much higher risk of dying from it than women treated within high-income nations. And part of this problem may be related to the cost associated with treating a womb cancer diagnosis, with estimates of between 10 and 27,500 UK pounds for each diagnosis. Given the number of womb cancers that are now being diagnosed, this represents a significant financial burden to national healthcare services. Lack of awareness of womb cancer as a disease, its risk factors and the symptoms associated with it continues to be a major barrier for women in accessing treatment for womb cancer, even within healthcare systems that have universal access. Studies have shown that even university-educated women and those that have been diagnosed with the disease often cannot identify risk factors for it without prompting. Whilst abnormal vaginal bleeding is the most frequent presenting symptom, this can often be put down to non-cancerous conditions such as fibroids, particularly among Black women. And indeed, many doctors make this same assumption, potentially leading to longer times to diagnosis among non-white women. Women at greatest risk of the disease, including those with obesity, have been shown to frequently underestimate their own risk of womb cancer, which may prevent them from seeking help if they do develop abnormal bleeding. And there are frequent misconceptions and misunderstandings about womb cancer, with many women, particularly from Black and Asian backgrounds, assuming that it is associated with sexual promiscuity, which means that they don't want to discuss it openly with their family and their friends. And there's also a belief that cervical screening tests can be used to detect all gynecological cancers, and that a negative smear means that you cannot be diagnosed with womb cancer. This even supposes that women have heard of the disease in the first place, which is often not the case. There are efforts to try to improve awareness of womb cancer, with education campaigns being run by pharmaceutical giants such as Eisai, with their Spot Her campaign to encourage women to talk about the symptoms of womb cancer and to reduce the stigma of the disease, and GSK's Red Dab, Red Flag campaign, which is aimed specifically at Black women. There's also IGCS's own Uterine Cancer Awareness Month, as we're talking about at the moment, and the Peach Ribbon to promote awareness and research into the disease. But whilst other cancers such as breast and cervical cancer have benefited from a celebrity association and charity backing, the absence of someone with a strong media presence to openly discuss womb cancer unfortunately makes it increasingly difficult to reach the general public. National organisations really do need to be called upon to promote awareness of womb cancer and for reproductive health to be a mandatory subject in schools, as well as encouraging individuals to present if they have symptoms of womb cancer. This might also serve as an opportunity to highlight risk factors for the disease and potential ways that girls and women might be able to reduce their own womb cancer risk. Indeed, womb cancer prevention is the only way we're going to be able to significantly reduce the number of diagnoses and deaths from womb cancer. But women need to appreciate that they're at risk of the disease and to seek or take up the offer of a prevention strategy for it to be effective. Understanding the mechanisms that drive the development of womb cancer has been critical in our appreciation of ways in which we could potentially prevent this disease. And data suggests that there are three distinct but interrelated pathways through which womb cancer develops. The most studied of these is the unopposed estrogen effect, which occurs often in association with obesity and is because of the aromatization of androgens into estrogen by adipose tissue. And estrogen acts on the womb lining and causes turnover of it. And this, if uncontrolled, can result in cells acquiring cancer-forming mutations. The second pathway is insulin resistance. And this often occurs both in the context of obesity as well as diabetes. And insulin and related hormones can act on the womb lining to promote cell turnover and survival, again, potentially leading to malignant transformation. And thirdly, there's the issue of chronic inflammation, which again can cause the womb lining to activate genes which are associated with cancer formation. And the womb cancer prevention strategies that have been suggested so far could potentially act on one or more of these pathways to stop womb cancer developing. And they include weight loss, physical activity, progestins, metformin, and aspirin. And whilst in theory these interventions could prevent womb cancer from developing, how effective they are in reducing the numbers of womb cancer diagnoses is yet to be established. Despite the pressing need for womb cancer prevention strategies, this is a very under-researched area. There have only been 3 randomised controlled trials published to date, all of which have been too small and of too short a follow-up period to comment on the effect on disease incidence. Much of the data that we do have, therefore, has had to come from observational studies. Given the association between obesity and womb cancer, it's not surprising that weight loss is associated with a reduction in womb cancer risk. Data from the Women's Health Initiative study which followed up almost 37,000 women over an 11-year period, suggested that as little as 5% weight loss over 3 years could reduce the number of womb cancers subsequently diagnosed by 40%. Interestingly, almost all women benefited from losing weight, although those with the highest weight at the start of the study benefited the most. The difficulty with trying to lose weight, though, through diet and physical activity is that it's difficult to sustain this in the longer term. And this was shown in the only randomized controlled trial that's been conducted so far, looking at lifestyle changes. And they showed that after a 16-week course aimed at reducing body weight and increasing physical activity, women did lose the weight, but then they regained a lot of this lost weight by a year after the study ended. And it had no effect on the rate at which the womb lining turned over. Bariatric surgery is the most effective weight loss strategy we know of and does seem to be effective in reducing womb cancer risk, with studies suggesting that women undergoing weight loss surgery have over a 60% lower risk of subsequently developing womb cancer than those that don't have the procedure. But bariatric surgery is not without potential side effects, and really changes how women and individuals approach their lifestyle and food. And there's also significant cost to the health service and access barriers that are likely to prevent it being taken up as a womb cancer prevention strategy at a population level. There's currently a lot of interest in GLP-1 agonists, which are effective treatments for diabetes and do seem to induce significant weight loss, certainly in the short to medium term. We don't yet know, however, whether these drugs are associated with a lower risk of womb cancer, as no studies have specifically looked at this. There's also very little data on how effective or safe these drugs are in the long term, and this is especially important if we're going to be considering a drug for cancer prevention. A number of studies have looked at the effect of physical activity on womb cancer risk. And as of 2022, there were 23 studies specifically looking at this, at which 10 have found a significant reduction in cancer risk in the most active compared with the least active group. Women needed to be doing at least 10 hours of total physical activity and more than 5 hours of vigorous activity, such as running, cycling, or swimming, each week to reduce their womb cancer risk by between 15 and 50%. These studies, though, had all had a number of limitations and had quite varied results, which potentially make their findings unreliable. My group therefore looked at data from the UK Biobank to see how much physical activity a woman actually needed to be doing to reduce her womb cancer risk. And this work suggested that a woman needed to be doing 7 hours of jogging a week to reduce her womb cancer risk by 10%, after adjusting for other factors associated with womb cancer, such as BMI, diabetes, and waist circumference. And this is unlikely to be achievable for the majority of women, particularly those at the greatest womb cancer risk. And it suggests that physical activity alone has probably got little value as a primary prevention strategy. The CAP2 study is the only randomized controlled trial we have that's looked at aspirin use and womb cancer risk. And this was a study conducted in individuals with Lynch syndrome who have a strong genetic predisposition to both womb and bowel cancer. And this study showed that by taking 600 milligrams of aspirin a day for 2 years, the number of womb cancers that were diagnosed reduced from 17 to 7, although the result was not statistically significant. A number of other observational studies have looked at the potential benefit of regular aspirin use on womb cancer risk within the population in general. And combining these results together suggests that aspirin regularly may lower womb cancer risk by around 12 to 14%. But what we don't know is how much aspirin somebody would need to take or for how long to see this benefit. Some of these studies suggest that women with obesity may benefit more from regular aspirin use, but other studies have not confirmed this. Researchers have also looked at whether metformin, a drug used to treat diabetes, can be used for womb cancer prevention. A short-term randomized study allocated women to either metformin alone or together with a lifestyle intervention to see if this affected the womb lining in postmenopausal women with obesity. After 16 weeks of treatment, the metformin had no effect on the womb lining and didn't lead to further weight loss, but it did cause a number of side effects. And this suggests that metformin probably doesn't have a place within womb cancer prevention. The most promising intervention for wound cancer prevention may well be progestin treatment, though. Observational studies from Scandinavia suggested that women that have used a Mirena coil have a 78% lower risk of developing wound cancer than those who've never had one fitted. And there's certainly evidence that the longer the coil is in place, then the greater the benefit observed. By the nature of these studies, they're often unable to control for many of the risk factors for wound cancer. So what we don't know yet is whether women at the greatest risk of developing the disease benefit to the similar extent. But what we do know is that women who have obesity are willing to have a Mirena coil fitted in order to be able to potentially reduce their wound cancer risk. A feasibility study conducted by our own group showed that after 8 months of treatment, women that had a Mirena coil fitted had significantly lower levels of Ki67, which is a measure of wound turnover. And this study was conducted in pre- and postmenopausal women, all of whom had a BMI over 40. Modelling suggests that widespread use of the Mirena coil among women with a high BMI could be a cost-effective approach to wound cancer prevention. So we now need some large randomized trials to determine whether the Mirena coil can indeed reduce the number of wound cancers diagnosed in high-risk women. And identifying women at the highest risk of wound cancer is really important because it means that we can maximise any benefit from a prevention intervention and minimise the risk of harm to a group that would otherwise be asymptomatic. And targeting interventions at women at moderate to high population level risk is likely to be the most effective approach to reducing wound cancer diagnoses. Risk prediction models are a useful tool to identify individuals at risk of disease or an outcome and can be used to select those for targeted intervention. So far, there have been 4 published models that have looked to predict wound cancer risk: the NIH AARP model, the EPIC, the recently published E2C2, and our own precision model. And all of these have included similar epidemiological variables, such as the age of a woman, BMI, reproductive factors, such as the age at which she started her periods and the age at which she had her first or last child, whether she's ever taken HRT, used the oral contraceptive pill, and whether she smokes or not. And adding in genetic or serum biomarkers doesn't seem to really improve the model's accuracy. Whilst all of these models have very similar abilities to discriminate between those at low and high risk of the disease, as shown by the C statistic, which is somewhere between 0.64 and 0.7, where they do differ is how well calibrated they are within their target population. And this is a measure of how accurately the model predicts wound cancer risk across the board. The NIH AARP model overestimated cases on external validation and included only white women in their model development and testing. The EPIC model, though, has also unfortunately never been externally validated, so we don't know how well it performs in an independent cohort. The recently published E2C2 model did perform very well on external validation within some of its cohorts, performed rather more poorly within the PLCO cohort. And this model has exclusively been developed and tested in white women, and also in women that have gone through the menopause. And that is a potential limiting factor for identifying premenopausal women for intervention. Because if we want to intervene to reduce somebody's risk of developing a cancer, then we really want to do so about 10 years before the time when they're most likely to develop that cancer. And so for womb cancer, this means looking at women when they are around between 45 and 60 years of age. And that's the exact age range that the precision model has been developed and tested in. This model also deliberately only includes details that women would know about themselves, and it avoids the use of blood tests or scans, which would make the model difficult to introduce into routine clinical practice. Whilst the precision model was developed within the UK Biobank, which has a rather limited ethnic composition, it has been externally validated in UK primary care records contained within the CPRD, and in these, almost 10% of women were from non-white backgrounds. Whilst there are limitations with using data that's been collected for clinical rather than academic purposes, it does mean that the performance of the model within effectively a real-world scenario has been assessed. And the precision model appears to be better calibrated and have improved discrimination compared with the earlier published models. A decision curve analysis is a means by which you can assess the overall performance of a risk prediction model, and it combines both the discrimination and calibration of the model in calculating the net benefit that would be associated with its use. And as you can see here, compared with the EPIC and the NIH models, the precision model offers greater net benefit across a range of risk thresholds. And importantly, it also offers greater net benefit than the alternative strategy of offering womb cancer prevention to all women. The next step, therefore, is to determine whether women will take up the offer of interventions to try and stop them from developing womb cancer. And in theory, women and GPs do appear to be willing to take up and offer a womb cancer risk assessment. So in 2022, I surveyed 660 women aged 45 to 60 who'd had an intact uterus and no history of womb cancer. And of these, over 95% said they would be willing to undergo a womb cancer risk assessment if they were offered one. And they told me that this was because they would want to try and reduce their risk if they were high risk, so that they knew what their risk was, because it could potentially save their life, and to be reassured that they were at low risk. And of the 115 GPs that responded to the survey, again, over 90% said that they would be willing to offer a womb cancer risk assessment within their practice, most often commonly as part of a well-woman screen. And the reasons that they wanted to offer it were to allow shared decision-making about how to reduce womb cancer risk, to save lives, because it would be cost-effective in the long term, and to allow research into potential prevention strategies. And of those potential interventions that we've already discussed, making lifestyle changes, including losing weight and increasing physical activity, appealed to the most of the women surveyed. So over 80% said that they would be happy to do so to reduce their womb cancer risk. Around 60% said they would be willing to take a pill each day if that was effective. And about half said they would have a marina coil fitted or have a hysterectomy if this would reduce their womb cancer risk. Fewer than 10% of the women surveyed said that they wouldn't take up any of the suggested interventions to reduce womb cancer risk. As it was an online survey, perhaps not surprisingly, women who answered it were much more likely to have a higher degree and to be of white ethnicity than the UK average. But these data do suggest that women are interested in womb cancer prevention and would take up preventative interventions if they're told that they're at high risk. So where does that leave us? What are the questions that remain outstanding? What we don't know is the most effective intervention to prevent womb cancer, and whether women at the highest risk of the disease will actually take up the offer of targeted primary disease prevention. Awareness of womb cancer as a diagnosis is low overall, particularly in non-white communities, who unfortunately are at higher risk of the disease and have poorer outcomes than white women. And outreach into these communities is critical to spread the word about womb cancer and the symptoms to look out for and what to do about them if they do develop. And this allows an opportunity to explore in more detail the potential barriers to taking up the offer of womb cancer prevention strategies within these communities, and to encourage eligible women to take part in any womb cancer trials that we conduct in the future, because historically these have been conducted in white women only. In the short to medium term, the plan is to conduct a feasibility study of women aged 45 to 60 within the Greater Manchester area in the UK, where women with a uterus are invited to attend for a womb cancer risk assessment. And these assessments can be done by phone, online, or in person on research vans located within the local community. And women will have their 10-year risk of womb cancer calculated using the precision model, and then the result discussed with them. And those at low risk, which is likely with a 10-year risk of below 0.5%, will be reassured and encouraged to maintain a healthy body weight and lifestyle, whilst those with a risk above this threshold will be offered the chance to take part in a randomised controlled trial. And we'll look at whether being told your risk of womb cancer causes women to worry, increases their anxiety levels, and if they make any changes to their lifestyle after they know their womb cancer risk. And the high-risk women who wish to take part in the study will be randomly allocated to one of two groups, either to receive weight loss advice alone or together with having a marina coil fitted. The weight loss advice will be given by research dietitians and be based on a calorie-restricted diet with the aim of losing 5% body weight over a 6-month period. And the marina coil will be inserted within the clinic. And the study will primarily report on the number of women that are recruited into the trial and the number that complete the 6-month follow-up period. But it'll also provide some early data on how effective weight loss and the Mirena coil are at reducing weight, the turnover of the womb lining, insulin resistance, and quality of life. The aim initially will be to recruit 100 women to ensure that the trial is feasible, and funding for this work is currently being sought. But ultimately, what we do need is a definitive trial to look at the long-term effects of weight loss interventions and Mirena coils on the number of womb cancer diagnoses. So in conclusion, intervention is urgently needed if we're to halt the rapidly increasing global rise in womb cancer diagnoses. Weight loss and progestions appear to be the most promising of a number of potential prevention strategies that have been investigated, but they do need to be compared head to head to see which is the most effective. Identifying individuals at the highest risk of womb cancer within the general population is needed so that we can maximise any benefit from interventions and minimise the risk of harm in an asymptomatic population. And this can be achieved by using a womb cancer risk prediction model such as Precision, and it will be a familiar strategy to doctors and nurses who already use a similar approach for risk assessing cardiovascular disease and other cancers like breast cancer. Clinical trials to assess whether this kind of approach to studying womb cancer prevention is acceptable to women are being planned and hopefully be underway in the very near future. So I'd just like to thank members of Team Womb and the Precision Modelling team, the women and the GP that have been involved in my research, and the support and funding provided by Rosetree, the NIHR, and Wellbeing of Women for this work. Thank you very much for listening.
Thank you, Sarah. That was absolutely fantastic. Just some really important points, obviously, that you've brought up through all of that. I suppose a question from the IG CAN point of view, as a network of advocacy organisations, you raise that awareness, is low, and that's something clearly we're trying to improve. But I just wondered if you had any thoughts about what we can best do as organisations to try to raise awareness and reach some of those women in communities maybe who are less aware and less represented.
It is very difficult, and it's where the big campaigns for some of the other cancer types, with big media presence, have really kind of pushed the awareness of breast cancer and cervical cancer to the front. And unfortunately, as I say, without a celebrity association, I think that means that we're not seeing the same levels of awareness. But on the ground, I think it's involving local communities in that work, having advocates within the community, people that are respected by the groups that you're wanting to reach out to is really important. And
no, certainly some of those strategies have been working very well, as you say, in cervical cancer, and that's something that I think possibly we can look at, the kind of education tools that we can have and things to encourage people, as you say, with that very grassroots approach. On a different level, we know that women do struggle with weight loss, and a lot of the public health campaigns have been very much targeted at individuals and their responsibility. But I just wondered whether you had any thoughts about public health policies that maybe take that onus away from the individual and are more targeted to the whole population.
So sugar taxes are one thing that's often discussed, and there are pros and cons to them. But again, that just makes it that bit harder for people to access or readily access the high calorie foods, subsidizing fresh fruit and vegetables, again, to make that more affordable, because this is part of the problem, that it's expensive to have a healthy diet and to partake in regular physical activity if that involves a gym membership, for example. And if you can make access to these things easier for people that struggle financially to make those, then I think that's a major step forward in dealing with what is a population level and global problem. This is no longer just a problem within high income countries. This is a problem worldwide, and often it's the poorest people that struggle most, because what they can access cheaply is not the food that really is the best for them.
Yeah, absolutely. And we've seen a huge change in the way we all consume food and are able to get to it, with differences in sort of supermarkets and things taking away local markets and access. So again, I think that's possibly something that as advocacy organisations we need to look at how that sort of access can be improved. And you mentioned the GLP-1 agonists. I know that they are having very effective, or are being very effective in weight loss, but I guess concerns are what those long-term effects are going to be, and it's not going to be the simple solution. But I don't know what your thoughts are about that.
Yes, that's it. I mean, there's increasing evidence to show that they are effective. They do seem to be associated with similar levels of weight loss to some of the surgical interventions, bariatric surgery. And we never thought that a medication was going to give us similar levels of weight loss, but that is a problem of the problem is we just don't know how effective they are in the long term, whether once you stop taking them, there's evidence that weight comes back. And that might be more detrimental if somebody's losing weight and regaining weight regularly in terms of increasing their womb cancer risk than somebody that stays at a stable but higher weight. And there are these concerns about some of the long-term side effects from them, whether they increase the risk of other cancers, whether they're associated with pancreatitis and problems like that. So we do need much more long-term data before we can say that they're going to be an effective drug for cancer prevention.
Thank you. And then just finally, if a woman now recognises having read more about womb cancer and things that she might be at risk, or indeed if a GP recognises that she may be at risk, what would be the steps that you would say they should take at this point?
So our common approach to making a diagnosis would be an ultrasound in the first instance to have a look at the thickness of the womb lining, and then a biopsy of that womb lining if it was thickened, and that could be something that they do in the outpatient setting or within if they do need a hysteroscopy, sometimes done within an inpatient setting as well. But yeah, it's recognizing that abnormal bleeding is a risk factor, and seeking appropriate investigation of that.
And even if they're at that stage, like before that, so they may not have abnormal bleeding, but they're concerned they might be at risk because of risk factors, including weight. Are there any? Would you say that using the risk prediction models at the moment are established enough, or whether we should just still be sticking with some fairly general advice about weight loss and increasing activity?
I think we don't have a lot of evidence to show that these models work when they're used prospectively on women. They're still being used within research settings rather than within clinical practice at the moment. But I think if somebody thought that they potentially were at risk of womb cancer because family members had been affected, or they themselves were at a higher weight, and they were thinking about what things they could do to reduce that risk, maintaining a healthy body weight, trying to lose some weight, increasing their physical activity, and if they were thinking about ways they wanted contraception and thought they were at risk of womb cancer, I certainly think that a Mirena call would be an effective approach to providing them contraception and probably will reduce their womb cancer risk. We just can't say for definite by how much, but I think that would be a very sensible approach.
And certainly, I think we really want to support your studies going forwards, and would be great to see that, as you say, expanded out into bigger studies. So, well, I just want to say thank you so much for your time today. It's been really fascinating, and just helping us to shine a light on this incredibly important disease. And I hope that it will be a very productive month in June as we once again focus on womb cancer and everything we can do to reduce its impact. So thank you.
Thank you.